So this is Grant Martzoff. I want to welcome everybody. Looks like we have quite a big turnout. I think we have 15 or 16 people on the call today. Welcome you to another Colloquium presentation that's hosted by the Nursing, Health Services, and Policy Research Hub at the Nursing School. I'm the director of that hub, and one of our big initiatives, we have a number of research cores that focus on various issues around health services, health systems delivery, around nurse practitioners, behavioral health services. But one of our big initiatives is doing these colloquium presentations. We think they've been really good. We've gotten feedback that people have really enjoyed them, and it's an intellectual space to share work and to talk about emerging issues in the field. And one thing that we really think is important is making these interdisciplinary. We want to create contexts in which folks from different schools and different disciplines get together and talk about common issues, because the complexity of the healthcare system requires very complex solutions. So in that spirit, we invited Brianna Lombardi to come present some of her work. Brianna is an assistant professor in the School of Social Work here at the University of Pittsburgh. She did her PhD at UNC Chapel Hill. How long have you been here at the University of Pittsburgh now?
I'm going into my third year.
In your third year. Okay, great. She is very interested in health services, particularly interested in understanding integrated behavioral and physical health care, namely the role of social workers, but broader issues as well of integrating care for folks with behavioral health conditions. We have a number of mutual friends. She studied with someone named Aaron Freyer, who's a very strong workforce researcher that I'm good friends with. And so there's a lot of intersecting vectors. So without further ado, I'm going to turn the mic over to Brianna. If you have any questions, please feel free to interrupt. But then at the end, we'll have a little bit of extra time for questions as well. And I'm going to go ahead and put my my camera down as well, so I can save some internet space. So you're on.
Thank you. Good morning. This was such a gloomy morning, but now the sun is coming out, so I'm appreciative of that. And thank you so much for taking the time to join today. And I'm excited to present to you about some work that I've been doing over the past few years, really digging into what is social workers' roles in integrated healthcare. But why do I care about integrating social workers into these systems? Is because the focus on wanting to address the social and behavioral health needs that we face. And I think, if anything, the last 6 to 8 months have really highlighted that we have deep-seated inequities in our society that impact individuals' health and well-being, and that behavioral health needs impact every part of our lives. So, when we think about, I'll be definitely focusing on social workers' roles, but I certainly will be also thinking about what are the broader systems that social workers are working in. So again, as Grant mentioned, I'm an assistant professor at the School of Social Work here at the University of Pittsburgh. I was an MSW student, or a Master's Social Work student here at Pitt as well. And after my MSW, I worked at Western Psych as a psychiatric social worker for several years. So I'm somewhat familiar to the Pittsburgh area, and I'm so grateful to be back. And one of the best advice I got when I was in my PhD program was to make friends with someone in nursing. And so I'm hopeful that this presentation will build my network of nursing friends. And so much of the work I'll present to you, we were inspired by other health disciplines, workforce research. So as Grant mentioned, a lot of this work is framed within the health workforce. Just wanted to shout out the funders for this work. I work primarily with the Carolina Health Workforce Research Center, which is directed by Dr. Freyer, as well as the University of Michigan School of Public Health Behavioral Health Workforce Center, which was funded by SAMHSA and HRSA, but now is just funded by HRSA and Dr. Angela Beck, who directs that. So a lot of this work has come from a health workforce perspective, in that social work, although has a long history that I'll tell you about in the health field, has not been studied much in the health workforce landscape. So really these projects were relationship that was built down at UNC that I've continued up here to really think about social workers' roles in integrated healthcare as and the new roles that they might fulfill. So when I talk about integrated care, I like to just use the most general definition that we can do. Oftentimes we think of integrated behavioral health when we think about integrated care, but I really like this World Health Organization definition that really describes integrated care as health services that are managed and delivered so that people receive health across a continuum of needs at different levels and with insights that go beyond the health sector. I think this is particularly relevant when we're thinking about addressing the social, behavioral, and physical health needs. That these are needs that go across the continuum of care, that they go in and without the healthcare system. And that, hopefully the plan is that if we address health early in life, that will be carried with them throughout their life course. But I wanted to acknowledge that integrated care has come from a chronic care management viewpoint as well, where we're specifically looking at complex health conditions. But again, when I'm talking about integrated care today, I'll talk a little bit more generally. So why are behavioral health needs important to address in integrated care? We know that individuals are attempting to access mental health care within their primary care setting. So the CDC highlighted in 2010 that about 20% of primary care visits have a clear documented mental health need. Unfortunately, most adults who need behavioral health care don't get the access to care that they need. And we also know that 50% of us will have some sort of mental health concern over our lifetime. But I think one of the strongest reasons why integrating behavioral health into primary care is that individuals who have concurrent physical and behavioral health conditions have increased risk of negative health outcomes. And they also have higher access to the ED and are more likely to be readmitted to the hospital, and unfortunately have lifespans that are anywhere between 10 to 25 years older. But I think also I wanted to really highlight in this presentation is not only thinking about integrating behavioral health, but integrating social needs. Now, I'm not going to give you the pretty slide that says, what are the social determinants of health? Because I'd like to really think we're beyond that. We understand that the way where we live, the inequities we have in our society physically impacts our health and well-being, where we live, our community. And so really the question now is how do we move towards addressing those needs? Certainly there are larger macro system interventions and policy changes that are needed, and I'll leave that work and discussion to my macro social work friends. But what specifically can we do within health systems to address the social needs on a more individual, or as a social worker would say, micro level? I would like to point out the NASEM report that came out in the fall of 2019 entitled Integrating Social Care into the Delivery of Healthcare, which was really about addressing social needs within health systems. This report was actually funded by primarily social schools of social work, which wanted to really highlight the role of social workers in health systems to deliver social care and address social needs. And I really love that this quote, that it's not about figuring out whether these social factors have an influence, but rather how do we as healthcare delivery systems, as health plans, as an industry, work on these factors in a fundamentally different way? How do we no longer say, oh, our social need is not what we do within the confines of this health system? And I'll talk to you a lot about how integrated care can hopefully address social needs. We think about so much about how, if you're a physical health provider, thinking about how things that you can't touch or you feel like you can't touch is influencing the client that you're sitting there with. You're supposed to be taking your medication at a certain time, but they don't have access because they have to work a 15-hour day. Or they're supposed to take their medication with dinner, but their food is inconsistently dispersed. Or they're not supposed to have a high salt diet, but that's the only thing that they can get. How some of these social needs are really influencing physical health, and how we could use integrated care or a team of interprofessionals to really address these different components. So now I'm going to switch over to talk a little bit more about social work. And again, I wanted to highlight that although I'm looking at this from a social worker's lens, integrated care is an interprofessional team sport. And I think that I would love to get your perspective on how social work could do better in describing our roles on teams and ways we can join more collaboratively with health systems. So social work, the practice and values do align well with healthcare transformation. Social work focuses on what we say the person and environment. This means how does the individual influenced by the house they live in, the community they live in, the neighborhood, and the larger society. Social workers at the master's level as well are experts in behavioral health. I'm not sure that most people know this, but about 70% of social workers who study at the MSW level get that direct practice training. So they are learning to screen, assess, and provide evidence-informed behavioral health interventions. But I think another strength of social worker is a knowledge of the social service system or the social service sector, and the knowledge of how to link individuals with those community connections and support. And as I teased you in the beginning, social workers have long been in healthcare. Sometimes when I read things, I'm like, wow, what is new is old again? I'm not quite, the old is old is new again, is the saying. Social workers have worked in health systems for over 100 years. This is a picture of Edith Baker, who is the name of the training program that we have at the School of Social Worker at Pitt to train social workers in integrated healthcare. That's run by Dr. Copeland. And Edith Baker was a social worker in the 1920s that was the president of the the American Association of Medical Social Workers that later went on in the 1950s to become the National Association of Social Workers, the more broader body. But you might have seen that social workers were more called hospital social workers or medical social workers. And certainly through the 60s, 70s, and 80s, these were the individuals who were in the hospitals and might be identified as discharge planners oftentimes. But with the ACA and the transition of healthcare out of hospitals, brick and mortar hospitals back into the community, that role of the medical social worker is changing. It's changing from being that discharge planner to the individual who is linking individuals to their community resources and providing behavioral health as integrated care has grown. And so are social workers increasing in integrated care settings? You can't be in an academic medical center and not think that integrated care is ubiquitous, that everyone's doing it. And what we do know is that it is growing, but it's hard to detect what that growth is for social work. The Bureau of Labor and Statistics estimated a 20% growth of social workers in healthcare settings over a 10-year period between 2016 and 2026. And certainly there has been federal investment in social worker training programs. So the Behavioral Health Workforce Education and Training Grant in 2014 was the largest federal initiative of its kind, and it provided training fellowships for 62 schools of social work to train about 20 social workers a year, specifically in integrated behavioral health. And this really focused schools of social work in order to be able to develop the competencies that are needed to move into this new era of what a medical social worker or a social worker in a healthcare setting might look like. I attempted, and my colleagues attempted to measure the collocation rates of social workers with primary care physicians. And I apologize to my nursing friends here today. We use primary care physicians as our counterpoint for co-located care. And certainly co-location is not synonymous with integration, but we thought it was a good way to kind of say, what is the opportunity for integration? And in this study, we used MPI data of social workers, and we geocoded the physical, work location of those social workers, and we geocoded the physical work locations of the primary care physicians, and we were inclusive there to family medicine, internal medicine, general medicine, OBGYN, and peds. And we looked at if they were in a 0.01, so that's about a 30 feet radius of each other in those geocodes, we classify them as geocoded. And so of the social workers in the MPI that had an MPI identifier, 26% of those social workers were physically co-located. So again, we will hope that this is just a starting bench point for us to really understand where social workers are co-located. And you can see by the image on your screen that shows the density. And so the yellow is more that the lower percentages of co-location in that area, and the purples are higher co-location rates. But you can obviously see there are wide swaths of the United States where there's no social workers present that had an MPI number.
So, Brianna, one thing that might be a point of intersection is we in the nursing school, Haley and I, have SKNA data. Are you familiar with SKNA?
I have heard of that from Aaron Freyers, but I heard that
Yeah.
social workers weren't in it. Are they in it?
Yeah, they are. They're in the
Okay.
data that we have.
Okay.
So instead of using that geolocation, we know what practices they're in, at least hypothetically speaking. So we could um, but we only have a limited number of states. We have Pennsylvania, West Virginia, New York, and New Jersey. So you could kind of test to see if your geolocation matches what they actually report.
I
So,
would love that. And I think we kind of went back and forth with a lot of folks in the health workforce at the various centers, because we know MPI data is not great. We know folks don't update their physical location as much as we might want from them. And the tricky thing, which is why I'm so excited that you mentioned this data, Grant, and I would love to look at it, is that social work doesn't have a data agreement with each state board. So we have
yeah,
no national roster of social workers. Some states don't even have a digital roster. They are kept in paper files for their
right.
licensure data. So that's something that the Behavioral Health Workforce Research Center has been really trying to do, is trying to get a minimum data set of social work. And social workers are a fickle bunch, because as much as we want to be there and be present in the integrated health arena, we have social workers who do lots of other things. And for those macro social workers who are working on community development, they say, why do I need to be counted in this? And I
Right.
don't want to be. So I would love that. And
Okay.
thank you. I'm so excited.
Yep.
I think Aaron's going to be really jealous if I get.
Yeah, well, now we haven't used it for social work, so I don't know how good the data is, but they're there. I see them in the file.
Yeah. The other data set that people have used is the data set from the census. The tricky thing about that is folks can say they're a social worker who don't have a social work degree. I kind of have mixed feelings about this, because, I do think people are working in social worker roles that are caring about communities and may be well trained. But, you wouldn't say to a nurse who didn't, pass their Nexus praxis exam, like, you're a nurse. So I do have some so I would love to, any data that we do is always curious to me. And I think that some of the ambulatory care study in the past, they haven't included social workers in particular in that list of who's in your practice. But if anyone else has other data ideas, I would love to chat with you about that. Is there any other questions right now before I kind of jump in? So hopefully I didn't lay the groundwork too well, and that I still have piqued your interest to talk about the 3 studies that will kind of, what I like to do is look at this problem towards understanding social workers in these integrated care settings to address social and behavioral health needs in different ways. No more questions at this time, at this moment. I will move forward to talk about 3 studies that I've worked on. Again, to look at it from different ways, and in some ways to try to triangulate our findings. So I will talk to you about a systematic review, a late in the class analysis that I did with primary data collection of social workers, and then our most recent endeavor, which is looking at the electronic health record, which holds a lot of promise, but has some difficulties for social work. So in the systematic review, we really wanted to search the scientific literature for rigorously designed studies that were housed in primary care settings. So they didn't actually need to be physically in a primary care, but linked to a primary care practice in some way. But most importantly, that the plan of care was developed and provided by an interprofessional team, inclusive of a social worker. We picked the published since 2000 to get the most recent literature and hopefully the literature that was influencing the decisions that were being made post ACA. And we didn't realize at the time how difficult it would be to really disentangle who was on that interprofessional team that was providing the integrated primary care intervention. But we stuck to our guns and we thought, if we really want to look at what social workers are doing, we need to know that there was a social worker in this study and not just say to ourselves, well, a social worker could do that. So really, we had some firm inclusion and exclusion criteria. And our two aims was to describe the functions of social workers on interprofessional teams and integrated primary care settings, and to compare the health outcomes of patients who are provided those cares. So we used the PRISMA guidelines, and we came to 32 articles of 26 studies. A few studies had several outcomes articles published, or they were looking at 24-month follow-up data. So 26 studies for 32 articles. And in our first aim, we took a list of social work competencies that was developed by Horowitz and Manolas, the citation on the left there, about what a social worker might do and might have to have the competency for. And so we created a list, we defined them, and then we had two extractors, me and someone else, go through each study and really identify what social workers were doing in each of these studies. And so you could see they were doing a wide kind of variation of things. And really from there, we kind of thought, all right, social workers are kind of doing everything. If we could condense down what are these roles that they're doing, we understand these tasks and functions that the studies are indicating, but what would we say their roles are? And these roles were influenced by our knowledge of integrated care models and from the literature review to really highlight this is what we were seeing social workers' roles in these studies. And so the first one was that behavioral health specialist, the person who's screening and assessing for a behavioral health need and providing brief evidence-informed intervention in those studies. Some of the evidence-informed interventions we were seeing was brief CBT, cognitive behavioral therapy, or brief problem-solving therapy. Then we saw that traditional care manager role, the person who is also screening and assessing for need, but is more of, might be the quarterback of the team, where they are making sure the client is connected to who they need to connect with. They're following up with them to make sure they got their needs met. And then the last one, which we entitled community engagement specialist, we're not wedded to that name, but really what we saw this was the person who was simply identifying a social need and then reaching out beyond that, primary care wall and referring the individual to that community support or resource. So they were really kind of confined to just addressing that social need. And it was beyond just screening for it. It was also really having a strong idea of what were the community connections. But what we also noticed was that although we saw these clear roles kind of shaping up, we noticed that they were overlapping. And then sometimes the social worker would be doing both the behavioral health specialist role and the care manager role. And keep that in mind, because this will be kind of the trend of as we kind of go through to try to understand social workers' roles. So just at a high level, our results from AIM 2, we broke down the studies by kind of the domain of the outcome. So an overall effect, behavioral health, general health and functioning, use of healthcare services, and cost of care. Overall, 19 studies reported significant effect over the control condition. But the strongest evidence of the studies were for behavioral health. Unfortunately, we didn't see much evidence at all, no difference in the substance use studies that were specifically targeting substance use issues. Overall, we saw positive general health, but no differences in mortality rates in the studies that measured that. There was mixed findings for healthcare services. There was some studies that reported a decreased use of higher level services, but others, were accessing their healthcare system actually more because they were having more contact with their care manager and such. And then overall interventions were cost neutral. So key takeaways from this systematic review was that social workers were performing different but somewhat overlapping roles. We were happy to see that teams inclusive of social workers can successfully impact clients' health and well-being, but obviously there's some measurement issues there. So for us as a team of social workers trying to understand the added value of social workers on integrated care teams, it was certainly impossible to tease apart the added value of a social worker in that role. And another issue that we noticed that even though these are team-based sports, team-based interventions, they're not measuring the level of team communication or collaboration. And then finally, you might have noticed that their social needs were not one of the domain outcomes because studies were not often measuring or attempting to address social needs or social risk factors. And so although that community engagement specialist was a role that we saw, we were not seeing that was one of the outcomes measured in their studies. So from this, we wanted to ask social workers, right? So we started to, learn about these different roles social workers might, but we were curious if social workers would also say they're doing wide swaths of things or if they had roles. And so our next kind of step was to do a primary data collection and eventually run a linked class analysis with that data. From the systematic review, but also from other reports, this was a study done by Aaron Freyer and us down where we asked social workers and students what they were most often using. And social workers report that they use a lot of different skills and interventions. And that if you ask a social worker, they're going to indicate they're using a lot. And that might tell you less about what role they're fulfilling on that team. And we were more interested in thinking about the roles. So we thought more about, okay, if social workers are doing all these different tasks, they might be fulfilling these different roles we saw. Maybe this could be a good thing and that social workers are flexible. But it's difficult to measure flexibility. The role flexibility, or Aaron Freyer has published a paper on skill plasticity, which is like that your skills can adapt to the needs of your team and your client's needs. So role flexibility could be a great factor to have when we're seeing different types of clients and we're kind of shifting towards different types of healthcare transformation. It can also be helpful to make sure clients' needs don't slip through the cracks. So if we have a team of interprofessionals that all have flexible roles, that in some ways these would overlap with each other and that an individual would make sure their needs are met. But again, as I mentioned, how do we measure flexibility in the data? And at the time, I was learning a lot about linked class analysis, which is an analytical method to identify different groups within a seemingly homogeneous sample. And so really we wanted to see if we could measure that social workers are in these different roles or in different classes. And I used a linked class analysis to attempt to look at that. Now, a lot of times you might see linked class analysis used in understanding again, different groups of people in a homogeneous sample. For example, substance use. Some people who misuse substances. There are folks who, if you look at adolescents, they might be more high-risk users, they might be lower or moderate risk users, and they might have these different components that make them fundamentally different, and we should target our interventions to those different needs. So linked class analysis helps us really identify these different groups of individuals. And for social workers who are, given a list of 25 different tasks or interventions, and they say, I do 15 of them, is there a way that we could slot the social workers into these different groups using latent class analysis to see if some of those tasks and interventions hang together, and that we could really say, okay, those 15 tasks you identify are meaningful in some way, versus just the average of 25. So again, the aim was, are there for this kind of sub-study, this larger study, was, are there meaningful classes of social worker roles in integrated health settings? This was a larger project that was funded by the Behavioral Health Workforce Research Center at the University of Michigan. And we recruited from the 62 schools of social work who received the funding for the 2014 HRSA Behavioral Health Workforce Education and Training Grant. And we developed an electronic survey. We had piloted it. You could see the previous citation from Aaron Frere was our pilot data. But certainly it was a convenient sample. We got about 50% of the schools of social work who were willing to send out the survey electronically to their students and field instructors. And on that survey, we asked them about the 25 tasks and functions and interventions that you had saw in the systematic review that was published by the Social Work Competencies and Integrated Care by Horowitz-Manolis. And we also collected some information on the patient population, the setting that they were in, and elements of integration. For example, if they were co-located or coordinated or fully integrated. And then I used M+ for LCA. In LCA, it is an iterative model process, and so you use pre-specified fit statistics to indicate the best model fit. So our total sample was more students than field instructors, but again, these were students who were in integrated field placements. They were predominantly female, they were predominantly white. And when we asked them, how often, do you use these tasks weekly, social workers reported that they used 15 tasks of these 25 at least weekly. There were some differences between the students and the field instructors. The field instructors indicated using more of the tasks and interventions. But again, we highlighted that if you ask social workers what they're doing, they're going to say a lot of things. But again, saying that they do a lot of things tells us less about what really their role is. So, sorry about your eyes. This is what the output can look like from a latent class analysis. But the best model fit for the data was a 5-class solution, which indicates there is possibly 5 different classes of social work. And in latent class analysis, I'll just point out on this slide and then I'll shield your eyes from this, is you want to see those distinctions. You don't want to see everyone kind of going in the same. You want to see some breaks. And you can see some clear breaks. There's some on the top and some below, which is indicating that there are different groups, that these different tasks might be clustering or grouping in important ways. I'm just going to highlight 2 for time to highlight the points that we discussed earlier, which is flexibility and kind of having a clean role. So we did see a very clean behavioral health specialist role. This was 12% of the sample. And these are the folks who, again, really focused on evidence-informed interventions for behavioral health. The next one I wanted to highlight is what we called the flexible social workers. So they were doing these care management roles as well as doing behavioral health interventions. This was 13% of the sample. So between these 2 classes, we really saw, again, that there are some distinct roles that social workers are filling, which one is possibly the behavioral health specialist role, but that there are also social workers who are doing these flexible roles, which are moving in between 2 responsibilities, possibly the behavioral health specialty role and the care management role. I would like to highlight that latent class analysis is sample dependent. This needs to be replicated with further samples. And it's less that we are clearly defining, but more testing that there is possibly that there are firm roles of social workers, but then there's also these social workers who kind of flex between different tasks. From this, one of the other takeaways is that, it's great to be flexible. Skill plasticity is going to be needed where everyone is working at the top of their licensure. And that, social workers could be that flexible person on the team. They might be able to address the social needs when they need to. They might be able to address the behavioral health need when they need to. But that makes it really confusing what their role is. And so maybe the double-edged sword of flexibility is role confusion. And the problem with role confusion is obviously that leads to the individual's burnout and feeling underappreciated on the team, but also that leads when we're not utilizing our team members well because we don't understand what each other are doing. And then again, we get to the measurement issue. So if social workers are functioning in these flexible ways, how do we measure the impact of a flexible social worker? And then most concerningly, how do we finance it? If you think about many of the service that we have right now out there, like collaborative care management, where that individual would fill a clear behavioral health role, or as an LCSW, a licensed clinical social worker on an integrated care team, you can bill independently for a 45-minute psychotherapy session right there co-located. But that really wouldn't help to figure out how we're going to finance that more flexible social worker. All right, hope you're still with me. I'm going to try to move through to our last one, which is the looking at electronic health records. So we looked at the literature, we asked social workers, and now we wanted to see if we could use the electronic health record to understand and describe social workers' roles and scope of practice in an integrated primary care. And there's been a lot written about how electronic health records can be harnessed for good, how we can measure social needs and identify folks who need higher levels of attention. And this was our first kind of dive into electronic health records. And honestly, it was supposed to be a first step into doing natural language processing, NLP, which would be able to analyze, millions of records at once. But we had some few hiccups, but we're hopefully going to get to that next process. So again, we really were just this is a one-year project funded by the Health Workforce, the Carolina Health Workforce Research Center, which was to examine the content and description of social work practice and documented in the EHR. And so we had three phases of this work. The first one is we conducted 3 focus groups with social workers from different primary care clinics within one health system to ask them about how they utilize the EHR, where they put their notes. Because in phase 2, we were working with data experts, IT experts in the Carolina Data Warehouse, which is a broker between us as researchers and the UNC healthcare system. And we had to tell them where to look for the notes for social workers that we wanted to read and abstract. And then finally, we abstracted and analyzed a random sample of 60 patients with a social worker note in a 1-year time period. So in phase 1, the most interesting thing we really heard was that there unfortunately was not a standardized way social workers were reporting how they documented their practice. So some social workers were saying they put it in a phone encounter. Some social workers said they would put in a clinical encounter. Some people would say they would call it, a subnote of the physician's billable encounter. And we started hearing that this might be an adventure we were not expecting. And then we also heard, though, that social workers are writing more in a narrative format. In some ways, they were reporting that it was difficult to condense all of the information that a client might give to them about their social needs, their behavioral health needs, into a very short note that they knew that their health interprofessional team wanted to read. But then we also heard, which was interesting, and we added, which was that social workers were really using the electronic health record to communicate with their team. In some ways, they weren't having regular face-to-face meetings, although they would have their drive-bys and saying, so-and-so needs this. But in some ways, if they needed to talk to the NP or talk to the physician, that they would type up a note and they would inbox it to their team members. So we really saw that this is a way that social workers are communicating social and behavioral health needs to their larger health team. So the second phase was retrieving the data. And again, this was, trying to have 2 worlds talk to each other. We quickly learned that most of the notes were easily organized by an encounter type, meaning a clinical encounter, a billable service. And that note types were not a great way to identify social workers. Another limitation we found is that on the back end, the health system used Epic. On the back end of Epic, there's 10,000 fields that we could select from in order to pull notes. And they were asking us which of those 10,000 fields that they would like for us to pull. And we realized that if a social worker touches a note, for example, if a physician writes, saw client has food insecurity, send to the social worker and inboxes that note to the social worker, and the social worker opens it, the social worker is now attached to the note, which is a good thing to think about communication, but it's a difficult thing when we're trying to extract just the social worker notes. So after a lot of processes, we were able to identify social worker only notes, we'd hoped, which is that the social worker had written it, and had entered it into the electronic health record. And so from there, we moved into the abstracting and analyzing the social work content notes. So again, we abstracted notes from a random sample of 60 patients. So we took all from one primary care clinic in the health system. If of all the patients that they saw in that 1 year time period, if they had a social worker note, then they were put into the pool, and from that pool, we randomly selected 60 of those patients. And we took all of their social worker notes from that one time period for all 60 of those patients. Then we try to use a standardized abstraction and annotation guide based on the literature and our findings from phase 1. And really, we were looking for kind of these two pieces. One, where the social worker was documenting their intervention, and then the second one was when they were communicating with the team. If they were talking about their intervention, we were looking specifically for kind of these different roles. Were they providing discrete interventions? Were they assessing or screening? Or were they referring and linking? But we also kind of kept it open in case we found anything in how they were documenting their practice that we could enhance our abstraction guide and adapt our lexicon to incorporate those things that we found. And the notes were double extracted by 20% of the notes were double extracted for accuracy. But we did a lot of the side-by-side with two master's level social workers who were part of the integrated healthcare training program. And so just I wanted to highlight that we had 60 patients drawn, but 425 notes were abstracted. So this means if an individual had at least one social worker note, they had probably a lot more. So on average, for an individual had 11 notes in a 1 year period documented by a social worker. So, that kind of clues you into that if a social has a note, we're talking about a higher need population. So on average, those 60 individuals had 11 notes, but they ranged from 3 to 52 notes in that 1 year time period. The average age was 64. It was 76% female, and we had a 53% white, 43% Black cohort. This is kind of just a picture that even though we tried to get that random sample, that there were still notes that we had to throw out. There was discharge summary plans that had a social worker addressed to it that was not a social worker written. So even with our best attempts to try to only pull in social work written notes, that we were still getting. So 425 notes were what we were looking for. And we also noticed that notes didn't just focus on one, the intervention, or two, communication, but often they overlapped, as you'll find things. And I'll highlight what we found in our data abstraction. So in our direct social work encounters, 32% of the notes were screening, but I think, highlighting what social workers are doing in integrated care, 65% of the notes were really referrals and care coordination, referring out to the community. And another thing we found that was interesting, that we'll get to the larger takeaways, is that each note really only captured one step of the larger intervention that social workers were doing. For example, if the physician identified that there was a food insecurity need and said, hey, social worker, will you call this client? So the client would pick up the call, and then maybe they wouldn't answer, and they would document that. And then the next one, the client called the social worker back, and the social worker would say, screened the individual for XYZ, identified this need, we'll make this plan. That's the second note. The third note, the social worker will have contacted maybe that social service agency to put in the referral, or to call several social service agencies to identify who's available and if the client qualifies for those resources. And that might be the third note. And then the fourth note is the social worker calls the individual back. So the tricky thing was that we were seeing pieces of interventions across a larger breadth of notes. But also, we were really curious when we saw this larger team communication. The predominantly was the MDs communicating with the social workers, but nurses, conversations with the entire team. Medical assistants or MAs were in conversation. And we noticed that there were back and forth communication, and it was really to update someone. So maybe someone identified a food insecurity need, they would tell the social worker, and the social worker would tell the person who referred them that that need was addressed. So just to highlight some of the examples, I won't read these to you all, but that we try to give representations of these different kind of buckets. So what a screening assessment note might look like, what a referral or connecting a service note look like, and what a discrete intervention note might look like. But you might see again that these are just small snippets of these larger narratives, which are difficult because they're dense and you need to read through to kind of pick apart what the different interventions social workers were doing. So big takeaways from this one is big data is so cool, but it has its limitations for social work and team-based interventions maybe more broadly. Because particularly for social work, it's difficult to quickly abstract social work interventions because of the narrative format, as well as having multiple notes. But also in the health system in that we worked in, it was organized by clinical encounters, meaning that a physician would put in, typically a physician would put in a clinical encounter, and that any social worker's notes would go under that clinical encounter that was addressed to that visit. Even if a social worker didn't see the individual on that visit, and so, if this is a team-based sport, but we're still kind of being organized under a physician's clinical encounter, it's really not highlighting the breadth of the team intervention, and it's certainly kind of instituting a hierarchy of whose note matters and whose note can be easily detected. It also gave us hope that possibly team communication might be measurable. Maybe there is a way for us to really use EHR not only to identify and track patient needs and outcomes, but also it could be a way for us to understand how teams communicate. And then again, though, we saw the concern that there needs to be a way to objectively measure and identify social needs. And so if you briefly saw from that slide, that the social workers were using, the PHQ-9 to assess for depression, which is a great standardized measure. But the way that they would screen for some of the social needs was more anecdotal, not standardized, and in a narrative format, which would make it difficult for you to quickly go through and extract that information. And if there was a need in one visit, the need wasn't always brought up in the second visit. So there wasn't really ways for you to kind of track the progress of that social need over time. So if health systems are really engaged and interested in addressing social needs, certainly finding ways to systematically measure and include it in the electronic health record is needed. So kind of, where I'm going next with this research, to support social workers' roles in integrated care, with the larger goals to address social and behavioral health needs. So we have some work to do, but it's exciting work. Certainly, I talked a lot about these different roles, but I'm curious about how these different roles might be funded differently in different models. And so the current next steps I'm working on is how do health systems finance integrated care? I'm looking into the psychiatric collaborative care management codes, if that behavioral health consultant is a social worker, and if that social worker is only funded by that code, or if they're also doing some side gigs, like seeing individuals co-located for 45-minute psychotherapy. And then also, how are we funding those flexible social workers that are doing? Certainly, we could go talk with Erin Freyer about value-based models, and maybe how some of these are better funded in those ways. And then also from the electronic health record project, we really wanted to dig in and learn more about how the social needs are documented in EHRs. And so right now, we're working on a project where we basically use Command F in electronic health records to find any of these keywords, and then identify who was the person who was documenting that social need and what intervention was used. But really the challenge and the goal is to harness social work's flexibility to add value and to improve population health. So it's just some next steps I was thinking about moving this work back from social work world into the larger interprofessional health services world, is thinking more about how we do interprofessional research. So we are encouraging interprofessional practice. Certainly team-based interventions are here to stay, but thinking about how do we measure interprofessional work? How do we measure the implementation and effectiveness of team interventions? And then how do we work on those projects as social workers, as nurses, as health services researchers, as physicians, as dentists, as pharmacists? How are we also modeling that in the research that we do? Certainly there's a continued need for interprofessional training. Um, in it's hard for us to tease apart what a social worker role is. So really, wanting to describe that flexibility to the larger health workforce. And then a continued understanding financing integrated care is critical, sustainable ways. And then finally, thinking about if we are committed as researchers to really focusing and caring about people's social needs, that we need to find ways to systematically measure and include in our research. So I'll leave you with a teaser, which is, okay, what does this all mean now in the time of the COVID-19 pandemic, which is that now social workers are moving that practice onto video calls. And this was a brief survey I did in partnership with the National Association of Social Workers, and I surveyed practicing social workers through their listserv. And this is on the left, their pre-COVID telebehavioral health use and their since COVID began, and 93% of social workers are using telebehavioral health or telehealth to predominantly talk with their clients. So this will be really curious to see now, how do we do integrated care over a video context? But again, here's my contact information if you're ever interested in talking more. And I'll open it up to questions. I hope I've saved us enough time for that.
Yeah, thanks so much for this wonderful presentation. I just want to point out that in many ways, this really illustrates sort of the potential and possibilities of health services research. Broad arsenal of methods using big data, but then also surveys to sort of get a real complete understanding of this phenomena. So this is really great. So we have about 5 to 10 minutes for questions. If anyone has any specific questions for Brianna.
Hi, Brianna. My name is Jennifer Seaman. I am in the Department of Acute and Tertiary Care. Thank you for a fantastic presentation. First, for the nurses, I like to, your eloquent description of the double-edged sword of role flexibility was so on point. I think we've all experienced that, and how it can really take us in the wrong direction. So thank you for, thinking about that. My interest, especially with the hub, is how do we look at a sort of a not traditional aspect of behavioral health, but I'm looking at care. How is care that is sort of palliatively informed, integrated into primary care for individuals with dementia and their caregivers? And so I'm looking at the CAPS, the new CAPS codes, and I would love to talk sometime about whether you have any experience with how social workers have been integrated into providing more of this whole person care to people with dementia in terms of home assessment, safety assessment, caregiver burden, and all the other dimensions of care. So I look forward to hopefully connecting with you in the future.
Yes, please. I would love to connect. And, really social workers in gerontology, the specialty, have really led that. And that's kind of another kind of thing about social work, is that we've got a lot of different specialists. Thank you for using the word whole person, because that's certainly how I think of it, right? Like, I am team, there's no health without mental health, and mental health doesn't have to be severe psychiatric mental illness. And obviously we're seeing from the COVID-19 that most people are feeling higher levels of stress and anxiety, caregivers of little kids like me, and also of their older adults. And so incorporating that is so important. It reminds me, a lot of the notes I read, it was the social worker communicating with the caregiver of an older adult and so it was, the caregiver calling and saying, hey, my mom is saying she needs this, she needs that, how can I help? And so certainly a social worker is not just talking with the client themselves, that they're talking with the team. And I think that, in some ways in integrated care, the person who is reaching out, is the one who's getting access to social workers, but possibly that is such a thing that we could maybe include in a standardized social worker assessment is who are the caregivers? How are we connecting with them? How are we engaging with them? And how would you like them to be included in your care, and how important that could be? I'm so curious about these CAPS codes, and I'm going to look into those. So thank you very much.
Okay, thanks.
I have a question, Brianna. I'm a PhD student, and I'm also an acute care nurse practitioner, so my background's in critical care. And I was curious, you noted that more interprofessional training is needed. I feel like in the critical care setting, we use social work all the time. They round with us. But when I was in my undergraduate nursing program, I had almost no experience with social work. And it wasn't until I was in graduate school that a lot of our simulations or some of our standardized patient encounters actually purposefully included interdisciplinary training in the SIMS. And I'm just wondering, is there any of that going on at the University of Pittsburgh with integrating social work students and nursing students? Because I think that is, that is in some ways where value between professions is kind of established early on, and how you utilize those members of the team.
Yeah, definitely. I only know at the graduate level, like you were, and that kind of made me think about that more, that you were mentioning at the undergraduate level. Certain here at the master's level, the School of Social Work participates in the Interprofessional Collaborative, I think it's called, which is like a larger group. You know, the tricky thing too about Pitt Social Work is we're not included in the health sciences, actually. I have to fight to get into the health sciences library because they don't classify social work in the health sciences here at Pitt. And so in some ways we are working collaboratively with other health disciplines. In some ways, social work is still kind of far out there. I do know that the Baker's Fellows, which is the integrated health training program, requires their students to be, part of that interprofessional day, but that's just one day. And how can we increase those opportunities is certainly something I'm really interested in. And thank you for mentioning the undergraduate, because we do have a bachelor's of social work program here, but it's a quite small program. And most practice at the social work level is at the master's level. And so although for undergraduate BSNs, they would be really curious, it's, graduate school, undergraduate, for some reason we don't talk to each other very well. But that's a really smart thing to think about. And I'm really curious to think more about that. Thank you. Any other questions?
Yeah. No. All right, so we are at the end of time. So if everyone can join me in thanking Brianna for the wonderful presentation. This is really great. Thank you.
Thank you so much. Thank you for your time. Please reach out. I'm so interested. And Grant, I can't wait to talk to you about the data.
Yeah, let's we'll set something up to chat, and we'll involve Haley because she's doing a lot of this work too.
Of course, yeah. All right. Thank you so much.
All right, take care.
Bye. Thank you all.